Welcome. My name is Richard Rosedale. I'm the Director of Education for the McKenzie Institute, and I'm here today with my friend, who I'll introduce in a minute, Georg Supp, and we're here just to have a conversation and for us to share some of our thoughts with you. Georg.
Yeah, hello. I'm here in Freiburg, Germany, whereas Richard is in London, Ontario, in Canada. And in these pandemic times, we found that most of the time, not many exciting things are happening. And then we noticed that we had a great time always when we had a chat via Zoom. And we had some couch conversations, just sitting on a couch and discussing some issues. And now we thought about why not sharing this with you. Yeah, Richard, I'm great to be here with you again.
Good to be here too. So one of the recent issues that came up was in regard to classification system, because we had this review that came out, and I think some people were a little bit kind of taken back and kind of upset by that. People that invested a lot of time and energy in learning a classification system, and they didn't quite know how to respond. So we had a chat about that, didn't we, Hugh?
Yeah, sure. Yeah, I think it was last year in October, or when we had our chat about this and the systematic review of Scott Talia-Ferry or something like that. Yep. And actually, I was not surprised by the results. I was not surprised at all, actually. So all the classification systems seem to work kind of the same way. So there's no superiority in one of them. And that is exactly what I would have just expected.
Yeah. So with that in mind, then obviously you use MDT, one of the classification systems, in the review. So if there's no difference between it, why are you using it? Why do you bother?
Yeah, why am I using it and why am I teaching it since more than 20 years if it's not superior? So first of all, it's not worse than anything else. It's not worse than the other systems. It's not worse than general approaches. So, but it's also not better. I agree. It's not worse, and for me, for myself as a clinician, it gives me a framework to introduce all the evidence-based stuff. It gives me a framework, and it gives me guidance, and that is what I get as feedback from clinicians, that the system itself gives them a lot of guidance. So just talking about do evidence-based practice in your practice, that's easy. That's an easy statement, easy to do, but hard to fulfill. And right. I think the McKenzie system is doable and in daily clinic, and there are so many positive aspects involved that it's absolutely worth to do it.
Yeah. So the structure also appeals to me. I mean, in my mind, I like to have some guidelines to know. And during my assessment, in terms of what should I really focus on and look at, and then in terms of my management of the patient, what do I try? When do I try it? When do I move on? When do I kind of progress? All those things. I like to have some kind of structure to help me guide, and I also am someone that appreciates that. It's obviously not everyone appreciates that or feels as though they need that kind of structure, but I personally do. I kind of agree with you.
It's a structure for the clinician and for the patient. So what I like, right, and what many people like, is the simplicity of the system, and also for patients to understand. So you can involve them from the first day, actually from the first minute, and doing the special way of testing, what the McKenzie guys do, involves the patient and gives patients a lot of responsibility and shared decision making in the diagnostic process. So, and that is one of the really positive aspects and the advantages of MDT.
Yeah, I think it's tough to argue with. I mean, what is there not to like about putting the patient at the center, where it's their movements and their responses and what they're telling you which drives the system and drives the decision making? And I love that when a patient comes back and says, hey, I was doing that exercise, I actually stopped doing it and I started to do the other one we tried, because the first one made my leg feel worse, and then the second one I did made that feel better. And so the patient's then able to kind of take over that process, understand that process, and I think that bodes well sort of for the future, because of course, you know, we need a system that is thinking not just about this episode now, but thinking about how is this patient going to manage this problem over the years to come. We know all musculoskeletal problems, most musculoskeletal problems are recurrent and persistent, so we need to really empower the patient to look after their problem down the road on their own. That's the idea, and I think that should be at the center of all. That should be a Physio 101 thing.
Yeah, I like the humility in the system. So it's a very humble way to approach patients.
And I know I've heard this. Well, it doesn't address. You know, it puts people in boxes. Doesn't address the pain experience, the broad range of pain experiences that people can get. So it doesn't really individualize the management. And take into account all these drivers of pain and disability. So what do you think about that, Georg?
That's interesting, because I've heard this argument a few times just lately. And what I did now, just out of interest, I checked our outcome system. So in our clinic, we use an outcome since one and a half year. We measure outcomes in a structured and systematic way. We're using Promise 29. And I just checked the charts of about 30 direction preference patients. So the direction preference, different regions, spine, the knee, the shoulder, whatever, and they're all fitting the category of derangement, direction preference. So they all are in that box, direction preference. So and then I checked the Promise 29, which has 8 domains. Anxiety, depression, sleep issues, and all the stuff, and also the physical function stuff. So, and what I found was a great diversity. It's not one box derangement, direction preference. It is always about an individual patient. And just classifying patients doesn't mean we kind of make them all equal. We put them in boxes. Just giving them a diagnosis doesn't mean we treat them all the same. And I don't get this argument.
Yeah, I think it comes from a lack of, you know, really understanding of the MDT system. And I think historically it comes from, MDT is just about extending everybody. It's just about self-treatment, and it doesn't really encompass anything else than giving everybody the same exercise to do. But even with that example, say we do find someone with a directional preference of extension, and we give them primarily the exercise to do. We may encourage them and reassure them, and everything might seem quite straightforward in the initial assessment, and some people may describe that, that's just a mechanical thing, and you're just giving the patient the exercise to do, and the patient comes back and they're responding well. But the next patient, they may still have a directional preference of extension, and yet they're fearful and anxious and need a lot of reassurance, a lot of encouragement. We need to encourage them generally to move. We need to reassure them. We need to talk about the imaging finding and how that's not related to their pain. So even though, sure, on paper, they're a derangement, the responsive extension principle, we've managed those patients very, very differently, depending on some of those drivers of pain and disability that we've also picked up on during our assessment.
That brings us back to where we started, the criticism on classification systems in general. So, and all other different classification systems, they have different boxes they put patients in. So, and I assume that also their boxes are not the same, or the patients they put in the boxes are not the same, as you just discussed. So, but one criticism from the systematic review, and at the end of the day was the main criticism, was that going through this education of the systems is cost extensive, so intensive, so it costs a lot of money. And health care organizations, they should think twice if they pay for this education for their employees, or a clinician spends money for this system to learn. So what do you think about this criticism?
Yeah, I think it's very difficult. So if you didn't pay money to go on courses, I mean, most people go on courses to some degree or other for further education. But if you didn't do that, and you read articles and read books, read textbooks, read articles, perhaps discussed among your colleagues, followed things on social media, then I think that takes you so far. But I think it's very then challenging and tricky to try and take all these different opinions and all these different components of the assessment of different types of classification, different types of management, and actually practically put that together. So I think people generally go on courses because most people need some sort of guidance, some sort of structure. They need to see, how patients are managed by other people, and then they need to make a decision in terms of, okay, this kind of approach suits me, suits my patients. I'm going to go ahead and use that. But to save that money, I think in a way, might be a false economy. I think you need to understand what's out there in terms of how people are practicing, and at some point make your own decision in regards to that. But I think also, and I think you've said this before, Georg, even if you go on, if I came on one of your courses, what would I be learning apart from MDT if I came on one of your courses?
That's one aspect is of course the MDT stuff, and it's the main aspect. That's why people are attending the courses. But on the other hand, people are learning about how to communicate with patients and how to optimize their clinical reasoning. They get up to date with the literature. So different aspects, different non-McKenzie aspects, which are also covered in these courses. And the second point is the fact that these courses are taught and the system is taught, it's also monitored. As you can see with the systematic review did check the efficacy of the systems. The fact that these systems and the educational system exists provides some kind of surveillance and some kind of monitoring and ongoing evaluation of what is being taught. So I think that's a positive aspect also, that it's not just something is happening somewhere. There are official classes, official courses run, and you can judge them.
Right. So you mean if you go through a system's courses and use that system, then at least that system itself has been evaluated in the literature and been it may not be evaluated to be better than anything else, but as you said before, at least it's been evaluated to be worse, and maybe just like with directional preference and centralization, at least we know some aspects of the system, have efficacy and have a lot of literature kind of that's supportive.
Something which is out there in public can be criticized and can be just monitored. But if it's not happened in public, or there are no official courses, it's hard to criticize things and to force some changes. And when you look at the initiative of BJSM, they are now talking about kind of checking course systems and give credit points for different courses, which might be the next step. So maybe the McKenzie courses will fulfill their prerequisites, and then they are BJSM accredited, or others are also. So we have a kind of a basic standard for course systems. But at the end, I think there are different ways to climb a tree, and McKenzie is one way.
Yeah, I think so, and I think for some people that appreciate that the guidelines, that structure, and know they are using some principles which are not easy to argue against. The principle of self-management, self-treating, putting the patient first, progression of forces, allowing to see what the patient can do before you get in there and put your hands up. Some of those principles, I think, are not really some of those principles are hard to argue against.
Sure, that's true. Okay, yeah, thanks, Richard. It was great to chat.
Thanks, Georg.
And thanks, folks. And now digest this and give us some feedback. And Yeah, and we catch up again next time. Bye. And bye, Richard.
Bye-bye.